A very good day, everybody. It's my honor and privilege to be invited to this wonderful oculoplastics webinar organized by the European Society of Ophthalmology. I bring you greetings from Singapore and the Asia Pacific societies that I represent. We only all wish that we lived in the good old days where we could travel, meet our friends, get inspired by our teachers and mentors, and build wonderful relationships with friends around the world. My personal thanks to Professor Christoph Hinsche for his kind invitation to share our experience on dacryoendoscopy in lacrimal practice today. These are my disclosures, but do not have any conflict of interest related to what I'm going to mention in this presentation. But I also like to acknowledge the contributions made by major treatises and textbooks on lacrimal surgery, which I encourage all youngsters to go through. Lacrimal drainage disorders are very common and significantly affect the quality of life. There are several newer advances in the means of understanding and technology, including dacryoendoscopy and endoluminal duct recanalization. This is even more important in this COVID era, where we are striving towards minimally invasive procedures, where we are able to either perform these procedures in isolation or in combination with other technologies and techniques. I'd like to pay tribute to the legends of dacryology, most of whom we have met and got inspired either directly or indirectly, and have made huge contributions to the field of our understanding of lacrimal disorders. Lacrimal disorders, the obstruction disorders, can be broadly classified into anatomic, which is the vast majority of patients that we manage, and the functional disorders itself. But once in a while, we do have patients who have a continuum between anatomic and functional obstructions itself. One of the terminologies which is not well mentioned in our literature is the concept of dacryostenosis, because it's all or none, it's neither all or none, but partial obstruction and multiple level obstructions, which can cause intermittent or permanent symptoms itself. And the treatment for a lot of these lacrimal drainage system obstructions was the DCR, be it external or endoscopic. These are quite mutilating procedures, especially it involves having an osteotomy done either through a transcutaneous approach or transnasal approach. And this is sometimes seen as a one-size-fits-all procedure, which in the modern days of targeted therapy is not that popular. A lacrimal drainage system obstruction is diagnosed both based on entity and the location, upper or lower system obstruction, whether it's a stenosis, is it a complete obstruction with fibrosis, or the occasional dacryolyths itself. And vast majority of them are diagnosed based on history, symptoms and signs, and a combination with lacrimal irrigation, the soft stop, the hard stop, the natural regurgitation, so on and so forth. And once in a while, the use of various imaging technologies, including a DCG. Dacryoendoscopy is something which is not really new. It has been in force for over 25, 30 years. Dr. Emmerich from Germany, Dr. Toru Suzuki from Japan, and Dr. Ray Havate have all been practicing this in one form or the other, from whom I've drawn a lot of lessons from. Just as how nasal endoscopy has completely changed the way nasal endoscopic surgery and nasal endoscopic diagnoses are being made, even for our lacrimal patients, lacrimal endoscopy is bound to change the way we understand and practice diseases itself. So we now believe the use of the endoscope makes it possible to see the pathology within not just the nasal system, but the lacrimal system. These are the various lacrimal microendoscopes that are commercially available, which I've seen and used, and we tend to use the polydiagnosed at this point of time because it's readily available with high resolution. Interestingly, it is made by a company from Munich, Germany. And these are the kind of images that we can get to see with the use of a lacrimal endoscope, picking up various cases of complete stenosis causing symptomatic obstruction, minimal symptoms with nice wide diameter of the nasolacrimal duct with those rugose mucosal folds, a patient with chronic dacryocystitis with mucopurulent regurgitation to lacrimal sac and nasolacrimal duct, and a patient with distal end obstruction with complete nasolacrimal duct obstruction. Here's a patient where the use of a diagnostic lacrimal endoscopy is useful, showcasing narrowing or dacryostenosis in the upper part of the lacrimal system. But as you move further down into the nasolacrimal duct, you will realize that the lacrimal duct itself is nice and broad, but the distal end, there's a complete obstruction itself. Sometimes you can use the endoscope to pick up even abnormal pathology, including the presence of foreign bodies, presence of lacrimal stent causing obstructions, and the occasional dacryolyth. Pictures courtesy Dr. Toru Suzuki. And we now are thus able to understand various lacrimal pathologies by looking into the lumen of the lacrimal system proximally in the upper part of the system, into the lacrimal sac, into the nasolacrimal duct, where you can see a stenosis like this, or near complete obstruction of the lower end, as you can see over here. So dacryoendoscopy is something that we originally were performing in the operating theater under general anesthesia, but we are now migrated towards offering it as an outpatient procedure using endoluminal anesthesia without any regional infiltration or general anesthetic procedures itself. Here's a patient where we've shown a relevance of a dacryoendoscopy in a patient with chronic dacryocystitis, whereby where you enter the canalicus, which you will see in a moment, you can see the canalicus itself is quite stenotic and narrow, as you can see over here. And as you move down the canalicus into the lacrimal sac itself, you can see it's a nice dilated lacrimal sac. And then you go into the nasolacrimal duct with these mucosal folds. Because of the stasis, there's always mucus retention with secondary infection, which results in a lot of mucopurulent material that you can see within the lacrimal sac itself. And a good amount of inspection will also be possible when you're actually not passing the endoscope into the lacrimal system, but actually withdrawing it. This is the distal end of the nasolacrimal duct showing a complete obstruction. And as you're withdrawing the endoscope from the lacrimal system through the nasolacrimal duct, you're able to better appreciate not only the dimensions of the lacrimal system, but the associated pathologies, if there's any. Not all patients with NLD obstruction and dacryocystitis have very wide or narrow lacrimal duct systems itself. And as you can see over here, as you move your endoscope back into the lacrimal canalicus, you can see the luminal pathology itself. What do we do along with the lacrimal endoscopy? It now helps us identify the location of pathology, whether it's a diffuse or a complete obstruction, or a focal obstruction or multifocal obstruction, and combine it with endoluminal duct recanalization procedures, which can be done purely as a mechanical procedure or using the various technology, including microdrills, trephination, cautery, radiofrequency device, or laser. I tend to use the mechanical procedures itself. Here's a patient where we're demonstrating the complete process of using the instrumentation for diagnostic and therapeutic purposes. We go through the history, followed by an examination. Of course, the gold standard examination, apart from the fluorescein dye disciplines test, is the lacrimal irrigation, where you're able to show regurgitation of mucus and mucopurulent material, as you can see over here, which tells you usually a distal level obstruction, if necessary, can be confirmed by the presence of a dacryocystogram. We then perform an office or operating theater lacrimal endoscopy, where again we're showing the narrowing of the lacrimal canalicus, and we enter the lacrimal canalicus. You can make out the junction of the canalicus and the sac can be sometimes narrow, edematous, and you enter the nasolacrimal duct. And as you move down the nasolacrimal duct, you can identify a distal end obstruction, which can be overcome. Here is an external view of the same lacrimal endoscopy showing of another patient, showing the edematous mucosal folds, dilated lacrimal system with mucopurulent material. And as you can see over here, you can overcome the obstruction mechanically using a lacrimal endoscope withdrawn into the sheath of the catheter and enter the inferior meatus, establishing recanalization. This can then be followed by a balloon dacryoplasty if it's a focal or lower end obstruction using the 90-second and 60-second cycles ×2, as seen over here. You can combine it with an inferior turbinoplasty, and then you can follow it up with bicanalicular intubation, as we do in about 80% of our patients. So these are the adjuvant procedures we do in combination with endoscopy as a diagnostic procedure and endoluminal duct recanalization as a therapeutic intervention. 80% of our patients end up having bicanalicular intubation. 20% of patients require balloon dacryoplasty. About 10% of them require inferior turbinoplasty, which helps postoperative monitoring of the inferior end. And most importantly, the concept of assisted patency described by Dr. Suzuki, where we perform recurrent lacrimal irrigations every 3 to 4 months in these patients as a long-term follow-up. So who are the patients we perform lacrimal endoscopy? We believe it should be ideally performed in all patients with acquired nasal lacrimal duct obstructions, primarily prior to doing a DCR, and secondarily for diagnostic if necessary. And of course, the limiting factor will always be the very young children because the diameter of the endoscope is about 1 to 1.1 millimeters. So in summary, advantages of lacrimal endoscopy include direct visualization of pathology intraluminally, the nature of mucosal obstruction, whether it's proximal, distal, or multifocal, associated foreign body if there's any. There's a better understanding of the nasal lacrimal duct obstructions. It no longer is a blind probing anymore, it's a vision-guided probing, which is what ophthalmologists should be practicing, and lends itself to offering minimally invasive procedures such as ELDRs rather than one-size-fits-all dacryocyst rhinostomy. This is a spectrum of lacrimal drainage procedures we still do. There are still a high number of patients with chronic dacryocystitis, with diffuse dacrystenosis, who have had multifocal obstructions where we still do an endoscopic DCR, but a good proportion of patients end up having endoluminal duct recanalizations. And this has changed, converted half the potential external or endoscopic DCR patients to ELDR patients. So in summary, I would like to close with saying that be not the first by whom the new is tried, nor yet the last to lay the old aside. Let's embrace new technology, have a better diagnosis rather than a blind procedure that we do sometimes for our patients. Understand and diagnose lacrimal drainage obstructions better. Be familiar with normal and pathological anatomy, including the variations. Have awareness of the various pathological entities, not just all of them are primary acquired nasal lacrimal duct obstructions. Know the appropriate indications, use appropriate technology to deliver the best outcome possible. Thank you very much, and I bring you greetings from NUH in Singapore. Invite you all to our 36th anniversary conference. Thank you very much.
So, Ganga, thank you very much for this presentation.